guys, welcome back. This is episode 1 of Urgent Care Stories. My name is Jim Allen. I'm a board certified physician assistant. And the first case that I want to start with today is something that came into my clinic a couple of years ago. And it was just an interesting case to see. So basically getting into it, this was a woman in her mid-60s. And the story basically went, she comes in for a one-day history of swelling in both legs. She's a bus driver, she's overweight, she has high cholesterol, high blood pressure, that sort of stuff. But she started driving back on the bus the day prior, and she started having some swelling in both of her legs. Had a little bit of pain, but nothing severe. The pain was worse after about an 8-hour shift driving the bus. And then after that, she went to bed that night and woke up the next morning. Pain was better, but still some discomfort. And so when she called her primary doctor, told her about this, they said, hey, why don't you get into the emergency department or the urgent care? So instead of going to the ER, she came to my urgent care. And so we do the evaluation of her. So initially, when somebody comes in with swelling of the legs, the kind of initial thoughts are some sort of a failure. So is this congestive heart failure, the pump not working effectively and you get fluid back up into the legs? Is this chronic kidney disease or acute kidney failure where the kidneys are not filtering things, so you have a change in oncotic and osmotic pressures causing the legs to swell? Is this liver failure, cirrhosis? That can also lead to bilateral or both side lower extremity swelling. Other considerations might be some sort of blockage. So sometimes if women are pregnant, they can cause blockage of the inferior vena cava and can prevent blood from returning back. Obviously, this woman being in her 60s, that's not a concern, but something on the differential for a younger female. And then the other thing would be infection, cellulitis types of things. Typically, it's not going to be both legs though. And then blood clots, deep vein thromboses. Again, typically not both legs, it's usually one. So in asking her history, so we come in, first thing you want to do every time you look at a patient is just look at them and see how stable do they look. Are they, sitting comfortably on the table? Are they alert and oriented and be able to have a conversation with you? Are they, winced over, excruciating pain? Are they like breathing heavily? Are they, not responsive? Just kind of those types of things would clue you into how serious this patient is. So again, she's totally alert with it, looks fine. Letting her talk and tell me the story, I'm just kind of looking at the legs, looking at her breathing, just kind of taking in some of that initial information that I need to. While she's talking, I'm looking at her legs and they look fine. She's an overweight woman, but I don't see any significant swelling. I don't see pitting edema. I don't see signs of erythema or redness or anything like that. So initially I'm thinking one of the failures, is this liver failure, kidney failure, heart failure? So those are the questions I'm asking about. Any history of those sorts of things? Has she had any heart attacks in the past? Does she have poorly controlled hypertension? Those would all kind of lead you down a certain path, either kidneys or heart in that situation. Obviously she's not pregnant because she's not of that age anymore. The other thing is, just with obesity, does she have peripheral vascular disease and just poor blood flow return to the upper extremities and to the trunk? Well, you don't see any varicose veins or anything like that. You don't see any stasis dermatitis, changes in color. So at this point I'm saying, hey, any history of blood clotting for you? And she says, well, yeah, about 15 years ago I did have a deep vein thrombosis. And I said, okay. So then if we have a previous history of deep vein thrombosis, we want to start to ask about the risk factors that would put somebody at risk for another deep vein thrombosis. And this gets us into something called Virchow's triad. So this is venous stasis. So this would be periods of immobility. Typically people who have had recent surgery and they're immobile from that. They've been on a long car ride or a long, flight or something like this. So this woman absolutely has a positive risk factor in the venous stasis part of Virchow's triad. She was on a bus for 8 hours straight. Second thing is a hypercoagulable state. So this would be smoking, history of cancer, recent surgery, anything that is going to form more clot in the body or an underlying clotting disease, factor V Leiden, protein C or S deficiencies, that sort of thing. She has no history of that, but she does have a history of a previous blood clot. So that something is slightly off about that. The other thing we start asking about, hey, any recent surgeries? And she says, well, you know what? I did have a knee arthroscopy for a meniscal repair about 2 months ago. and that's where she was kind of laid up for a little bit of time, and then she just started getting back to work. So again, it's a small surgery, but it does cause some clotting risk, and so that is certainly a factor that we would want to consider. The last thing is venous injury, so some sort of trauma to the vein. This can be an autoimmune condition, this can be surgery, various things like that. And so she has risk factors in all three of these areas. So while both legs are swollen, and typically in a deep vein thrombosis you see one, she doesn't have any history to suggest a failure of an organ system, so we need to get an ultrasound of this lady. So now the top of my differential is bilateral deep vein thromboses. I say, look, your Homan's test is negative. I don't feel any palpable cords. There's not a significant amount of edema to both legs. They actually look pretty good. I've got good distal pulses. So I said, look, I think this is something just transitory, just getting back on your feet, but I can't rule out a DVT, so I need to order an ultrasound. So that's exactly what we did. We ordered a bilateral lower extremity ultrasound, and sure enough, she had deep vein thromboses, blood clots in both legs. I think the clot was pretty extensive. I think it was mid-calf to mid-femur on both sides. So that's a pretty significant amount of clot burden. So what do? Well, we put that person on some sort of anticoagulation. So I usually like to go with Eliquis. It's got better data behind it than Xarelto, and you don't have to worry about monitoring like Coumadin or injecting like heparin. But again, it just depends on the patient, costs, and what they're willing to do. So we get her set up on the Eliquis. Now, the important thing to remember about deep vein thromboses and blood clots is there is a increased risk of pulmonary embolism. Now, pulmonary embolism is basically a clot from the deep vein in the leg, breaks off, it goes up through the vena cava, into the heart, into the right atrium, right ventricle, and then back into the lungs. And that's the area where the volume of the blood vessel starts to get narrower again, and that's where it can clot off. Signs of a pulmonary embolism: chest pain, shortness of breath, rapid heart rate. Those are things that we want to worry about. So again, once we've made the diagnosis that there's a deep vein thrombosis, that's the next thing we're asking is, hey, are you having any chest pain, any shortness of breath, anything like that? She says no to all those things. So at this point, we put her on anticoagulation, and then we tell her, hey, look, the first 1 month after a deep vein thrombosis, 50% of patients develop a pulmonary embolism. So it's a very high number. And pulmonary embolisms can be fatal if they're a large enough clot. So we put her on anticoagulation, elevate the legs, get the swelling down, that sort of thing. The body will break the clot down over time, but important things to worry about is looking out for that chest pain and that shortness of breath. The important lesson that I had with this case was to, number one, listen to your patient. So there was a famous doctor decades ago that said, listen to your patient, they'll tell you their diagnosis. And I really believe that that is true. You have to understand what they're telling you, but she was telling me, I've been immobile, I have a history of a blood clot, I don't have any history of organ failures, the legs are both painful and swollen, and that's enough to say, hey, we need to get an ultrasound to rule out a blood clot. So anyway, listen to your patients. You know, you need to know how to ask the right questions. You need to know what they're telling you, whether it's important or not. But make sure that you do listen to your patient, because they're gonna tell you their diagnosis even if they don't know that they do. So that was an interesting case. That was the first time I'd ever seen blood clots in both legs at the same time. It's pretty rare to see that. But that was our case for today, guys. So hopefully you learned something new. If you've experienced a case like this yourself, please, write down and share kind of your experiences there. If you have any questions or comments, leave them down below. Like and subscribe to the video series if you like what we're doing here, and I will see you guys in the next one.